Good afternoon, everybody. My name is Barry Hoffman. I am the Associate Dean for Clinical Affairs in the College of Health Professions and Sciences. We're very excited to bring to you today the edition of our Up to the Minute in Clinical Care series, surrounding the topics of concussion and vestibular therapy. We have three distinguished clinicians joining us today to share their expertise from the Central Florida community and discuss their approaches to treatment with this concussion population. So let me go ahead and start the introductions, and then I will turn it over. First, I'd like to introduce Anita Burkhalter. Anita is a speech pathologist and has over 9 years of experience. We're proud that she has graduated from the University of Central Florida with her bachelor's in psychology and communication sciences and business degree in 2008. Degree. She has worked in a variety of adult settings ranging from acute rehab, skilled nursing, and outpatient rehab. Anita currently works with the AdventHealth adult neuro program in the East Orlando campus, and she is part of the Neuro Clinical Ambassadors program, the concussion team, and the lung transplant program. She has a strong passion for neurorehabilitation, specifically with brain injuries. So welcome, Anita. I can't wait to hear your discussion. I also want to introduce Lauren Whilden, and she has been a physical therapy assistant for over 6 years. She graduated in 2015 with an associate's in applied science, and she's worked in New Jersey for 2 years before relocating to the Florida area. She has worked in the neuro rehab realm for 6 years in various settings, including acute care, inpatient rehabilitation, and outpatient. Currently, Lauren works for AdventHealth in their outpatient adult neuro program in the East Orlando campus. So welcome.
Thank you.
And last, I would like to introduce our very own Dr. Rick Beato. And let me just pull up a little document here. So Rick is a clinical assistant professor and director of the Doctor of Physical Therapy program. I'm sorry, let me say that one more time. Dr. Beato is a clinical assistant professor in the Doctor of Physical Therapy program at the University of Central Florida. He is the director of in Orlando Health's neurologic residency program, earning his Bachelor of Science degree in Physical Therapy from the University of Perpetual Health and his professional Doctor of Physical Therapy degree from the University of South Dakota. He is board certified specialist in both geriatric and neurologic physical pain therapy. Dr. Beato is the immediate past chair of the Geriatric Specialty Council and is a current member of the Neurologic Specialty Council on the American Board of Physical Therapy Specialties. He is a certified exercise expert for the adult aging by the Academy of Geriatric Physical Therapy and is trained in neuro-integrated functional rehabilitation and habilitation treatments for stroke and brain injury, as well as LSVT-BIG and PWR for the Parkinson's disease. Dr. Beato is a recipient of the Federation of State Boards of Physical Therapy Outstanding Service Award. He is the current chair of the Florida Physical Therapy Association's Neurologic Special Interest Group, and he has been published in peer-reviewed journals, including the Journal of Stroke and Cerebral Vascular Diseases, Journal of Geriatric Physical Therapy, and Physical Therapy in Sports. So I'm going to turn this over to these fabulous speakers. We can't wait to hear what you have to say. For those of you who are joining us and you have questions that arise during the presentation, please use the question link, and Dr. Beato will be interspersing those questions either throughout the talk today or at the end. Welcome, everybody.
Thank you guys so much for having us. Again, my name is Anita and this is Lauren, and today we're going to be talking about concussion and vestibular therapy. Okay.
So first we want to identify the objectives of the lecture. So identifying red flags in the evaluation of concussion, identify the clinical presentation trajectories that guide our interventions of rehab, and understand the key players in the interdisciplinary management of concussion and their role in the recovery of the patient.
So what is a concussion? A concussion can be defined as an elaborate pathophysiological process that affects the brain as a result of direct or indirect trauma. This trauma, in turn, results in transient disturbances in the brain function, and the diagnosis is usually made clinically, and therefore there is no definitive tests or markers. So the CDC actually includes concussion as a part of the TBI and the mild TBI data that we're going to discuss in a little bit. So based on the CDC guidelines, or sorry, the CDC website, in 2014, there was approximately 2.5 million TBI-related ED visits in the United States, including over 812,000 among children. Rates of TBI-related ED visits were the highest among adults ages 75 and older, young children 0 through 4, and individuals 15 through 24 years old. It's estimated that 1.6 and 3.8 million treated and untreated sports-related concussions occur each year, with 75% of the annual TBIs being mild TBIs. The most common ones that we see in our concussion program are usually motor vehicle accidents, sports-related injuries, and falls. However, they can be blast injuries also. So how is it diagnosed? Unfortunately, it's usually diagnosed with a negative MRI and CT scan. It's usually then followed up by symptoms, cognitive, emotional, and sleep disturbances. Because there's all these negative CT scans and MRIs, it's really, really hard for doctors and families and patients to really understand and believe and even acknowledge that it's a true injury.
So oftentimes there's verbiage that's used to kind of downplay the severity of TBI or mild TBI. So you might hear people say something along the lines of, you know, I had a bump on the head, or I saw stars, or I knocked a screw loose. And those are all, you know, verbiage that really we need to kind of get away from and acknowledge the impact that concussion has in our sports related injuries and also our aging adults with falls. So what we're looking for with red flags, prior to the physical therapy and speech therapy evaluations, we want to make sure that they have had their issues medically addressed. So the Canadian CT head rules are we're going to utilize those to guide when imaging needs to be taken. And that imaging should have been done prior to therapy intervention. So things like altered mental state, loss of consciousness, emesis, severe mechanism of injury, severe headache, signs of basilar skull fracture, age 65 years or older or under 2 years of age, retrograde amnesia greater than 30 minutes, or post-traumatic seizure and suspected skull fractures. So they should have had some type of CT imaging of the head prior to therapy, if any of those apply. If not, we would refer back to medical prior to intervention. Identifying any neck-related injuries prior to therapy is also important. So the Canadian C-spine rules would include tenderness, posterior mid-cervical spine, focal neurological deficits, decreased alertness, intoxication, other distracting painful injury, age 65 years or older, dangerous mechanism of injury, paresthesia in the extremities, or unable to actively rotate their neck.
So what kind of symptoms do we see in our clinic? A lot of the symptoms are very similar, but we see a lot of post-traumatic amnesia, retrograde amnesia, confusion, dizziness, headaches, and I think headaches might be like the most severe one that we see and most common. Visual issues, balance problems, fatigue, personality changes, light and noise sensitivity, vomiting, and loss of consciousness. So here's another list of some symptoms that we might see in the clinic post-concussion. Now, they don't have to have every single one of these to be considered having a concussion. As you remember, it's a negative CT scan, a negative MRI, along with symptoms. But they can have maybe they only have one symptom or two symptoms, but they don't have to have all of them.
So in order to predict recovery, there was a study done in 2011 by Lau et al. And really what they wanted to look at was, is there any relationship or correlation between sideline symptoms in athletes post-acute concussion, and what kind of predictors can we look for possibly to determine if they might have a rapid recovery versus a protracted recovery. And the results are actually surprising, at least they were to me, because you would think with vomiting and loss of consciousness that those would be more indicative of a severe concussion, but those sideline athletes actually had a more rapid recovery than those with dizziness. So dizziness is number one for protracted recovery. The patients that tend to present with that tend to have a longer recovery. So there's other factors that can help guide us in predicted recovery. So females tend to be more symptomatic and have worse clinical outcomes than males. Age, so adolescents 13 to 17 are at higher risk for persistent symptoms after sports-related concussion specifically, and migraine. So patient or family history of migraine has been correlated to prolonged recovery.
It's also thought that a patient that has had a concussion is at a greater risk to having an additional concussion. And this can be due to a lot of different factors. Some of them include residual side effects from their first concussion, including impulsivity and safety awareness, or it could just be age and lifestyle choices.
So there is strong evidence that a history of a mood disorder or psychological history has negative influence on the outcomes. But there is still mixed evidence regarding relationship between a history of concussion and protracted recovery of additional concussions, as well as mixed literature on the significance of history of learning disabilities.
So how do we manage a concussion? So in our clinic, we do a multidisciplinary approach. We have a concussion team made up of MD, physical therapy, speech therapy, and audiologist. And then as needed, we refer out to the neuro-ophthalmologist and the neuropsychologist. The biggest part of the concussion management is having this team, a specialized team with open communication with all members and referring out as needed. So speech therapy evaluation and concussion. So during our speech therapy evaluation, I spent a lot of time on doing a patient interview. I want to identify their triggers, identify their symptoms. Do they have any notice? Do they notice any cognitive changes? Are they having any difficulty with time management? Are they having difficulties with emotions? How is it harder to complete now than it was before? So I typically try to understand what has changed for them since their accident, even if it's the smallest thing like misplacing their keys, forgetting to clock out at work. Our treatment is usually and ideally center-based treatment or patient-centered based treatment. So with our goals being them to return to prior level functioning. And this information helps us guide our treatments to make it more centered based and so that they get the buy-in from the patient to continue. So during the evaluation, I make sure that I'm assessing their attention, their executive functioning skills, including time management, planning, problem solving, impulsivity, organization. Unfortunately, speech therapy in general doesn't have a lot of variety of tests to utilize to actually assess these. Neuropsychology has a little bit more. We currently use the BADS and the CLQT along with self-questionnaires, but we do a lot of indirect patient interviews, although it's not exactly ideal. All right. In a therapy and evaluation, we tend to see the primary deficits being in the areas of executive functioning skills, processing speed, attention, usually dual and divided, memory recall, immediate and short term, and then naming. So during my evaluation, I tend to talk to the patients and kind of just give them a situation. I always say, I give them the example of driving in the rain. And I say, imagine that you're in a car, you're listening to music, you're driving to a new restaurant, you're not familiar with this area at all. Then it starts to rain. Well, what's the first thing that you do? You turn down the music. You decrease your sensory input. It allows you to more focus on where you're going and what you're doing. When you're having concussion, a lot of the times you're driving in the rain all the time. And that kind of helps the patients and the family members understand what they're feeling and why they get so confused and they can't walk and talk at the same time. And it really kind of just puts everything into perspective. So some things I like to consider when I'm doing my evaluation is, when was the concussion? Is it considered acute? Like, is it within 2 weeks, or was it 30 days ago, 2 months ago? What are their symptoms? Do they have a headache? Are they sensitive to light? What kind of medications are they taking? Some doctors prescribe headache medication. Sometimes they prescribe anxiety medication. We want to figure out what kind of medications they're doing and how are they using that medication. Is it as needed? Are they taking it when their headache reaches a 6 out of 10? Or are they taking it every single day as just because? I want to know if they've had any previous head injuries, what their prior level of function was, their goals and their barriers, and any comorbidities. So in therapy for speech, we do a lot of management of symptoms. So headache, mental fog. I usually like to have them do a headache diary. I make them write down when they had their headache, when it started, what were they doing before their headache, what did they do to relieve their headache? Was it going into a quiet room? Was it turning off all the lights? Was it listening to music? And then we work on compensatory strategies. How are you going to avoid those symptoms? Are you going to wear, earplugs? Are you going to wear a hat? Are you going to wear sunglasses? How are you going to cope with your day-to-day life with all those symptoms? And then specifically with memory, we do lots of memory notebooks, alarm clocks, scheduling. We also do improved processing, and those can be like the Stroop, if you guys are familiar with that, where it gives you a color and written in a different colored text. So it'll say blue, but it'll be written in red. And we do those kind of things to help with their processing speed. We do dual attention, which is like walking and talking, working while playing noise. I tend to give them like some kind of really hard, like a Sudoku or some kind of deductive reasoning puzzle. And then I play bar sounds in the background or coffee noise, anything from a restaurant, to kind of really distract them and say, can you work in an environment when you're in school? So say you're going to UCF and you're in a lecture of 300 people, there's people talking, there's people coughing, can you focus? And then I'd work a lot with executive functioning and planning and sequencing and problem solving. And then our goal is for them to return to work and return to school as they were before. So the next slide I'm going to show you is an example of one of the dual tasking, and hopefully it'll work. And if you guys want to turn up your volume, it's kind of low, but this is a dual tasking activity that I do very, very commonly in our therapy. And this is kind of the whole situation of when it rains. Can you do 2 things at one time? So let's watch it and then we'll discuss it, okay? So make sure your volume's up because it's really low.
All right, when you're ready, let's do the rhythm we talked about. Okay, so right now you're doing it in a clockwise manner. Now I want you to name animals. Dog, cat, bird, horse, fish. Now I want you to reverse your order counterclockwise. And now I want you to count by 2, starting from 0. 2, 4, 6.
So as you can see in this video, she struggled when we changed the direction of the tapping. And then I added in another task, and I added in an addition task versus a naming task. And as you saw, she paused. And that's what that's a good example of dual tasking, doing the 2 different things at the same time.
So physical therapy intervention post-concussion. My role as the physical therapist assistant is follow-up post-initial evaluation. I implement the interventions, and I also perform data collection via our outcomes measures per our clinical practice guidelines. So what we want to do is categorize these patients and put them into these clinical profiles. So you can see that post-concussion has a lot of different trajectories that these patients can take. We're going to focus today on the vestibular and the ocular aspect, but you can see cognitive and fatigue, which speech therapy capitalizes on. Post-traumatic migraine requires a lot of medical intervention. The cervical spine we talked about, where we want to clear the cervical spine prior to seeing them, and then we can address any orthopedic issues. And then anxiety and mood, where a lot of times we tend to refer out to neuropsychology. It is important to know that these patients can fall into multiple categories, so it's not just one trajectory that we are addressing with them. So patient history, the physical therapist upon evaluation would be looking at the mechanism of the injury, exertional versus traumatic. So exertional would be more of your coop, counter coop injury, whiplash associated versus the traumatic, a football tackle. Date of injury, so are they still in their acute stages versus is it more subacute versus chronic issues post-concussion? Symptom baseline and symptom provocation, so where are they at right now as far as symptoms go? And we're looking at headache, nausea, dizziness, and mental fogginess, and what provokes those symptoms. How often are those symptoms occurring? And how long does it take for those symptoms to resolve? What factors alleviate the symptoms? Acute headache and migraine history, if they're in that headache, migraine category, anxiety and depression history. So we talked a little bit about how mood affective disorders have been shown for protracted recovery. So we utilize clinical practice guidelines that are thoroughly researched, but they still are in progress of constantly updating those just to new information. So concussion subjective information. So we utilize a couple different type of subjective questionnaires to kind of get an idea of where the patient's at. So if dizziness is one of their symptoms, we want to look at the Dizziness Handicap Index. This consists of 25 questions rating occurrence of symptoms, onset of symptoms with different activities. The patients are going to rate those statements as occurring no, sometimes, or yes. And the good thing about that is it does break down the results into emotional, physical, and functional subscores. The activities specific balance confidence scale, we just shorten it to the ABC. That consists of 16 questions where the patient would rate their confidence in an activity, and they're going to rate that 0 to 100%, 0 being not confident at all to 100% being it's not a problem, and that goes in 10% increments. The River-Me Post-Concussion Symptoms Questionnaire, so that consists of 16 questions and symptom lists where the patient rates the severity of those symptoms on a 0 to 4 scale. There's also areas where you can write in patient-specific issues and they would rate their symptoms with those as well. And finally, the Neck Disability Index, so if cervical pain or issues are something that we're looking at, we would have them fill out this. So this consists of 10 questions where the patient selects 1 to 6 statements as best describing their symptoms. So those categories are related to neck pain with functional tasks such as driving, concentration, headache, self-care, etc. So based off of their symptom presentation, we're going to, as I said, talk about those clinical trajectories, specifically the vestibular and the ocular today. So vestibular, they might have symptoms such as mental fogginess, dizziness, sensitivity in visually stimulating environments, i.e. the grocery store, on a highway with passing cars, and then nausea. The ocular trajectory, so we're going to see patients that complain of eye strain or pressure, difficulty focusing, frontal headache, and decreased attention. So then our objective measures. So what are we looking at as the clinicians? Balance and gait testing. So there are quite a few tests that we can perform. Balance error scoring system, which is the best test. And that we're going to go on to another slide, and that's going to show the patient in different positions, and we're looking for how many errors they make. The clinical test of sensory interaction on balance, so we shorten that to the CAT-SIB. That's 6 different positions that the patient's in on level and compliant surfaces, eyes open, eyes closed, and how they're able to maintain their balance. The functional gait assessment, so that consists of 10 walking tasks. One of the most triggering ones that we find is one of the components is walking with horizontal head turns. That tends to bring on the most symptoms, especially if they're in that motion sensitivity or dizziness. The dynamic gait index has 8 walking tasks. And then the last 3 have really been shown to be a little bit more sensitive when the patients are out of that acute stage. So the HIMAT, the high level mobility assessment tool, consists of 13 items, and that includes things such as running and skipping and jumping. The Cobalt has 8 conditions versus the CAT-SIB 6 conditions. And the dual task walking. So Anita talked a little bit about how dual tasking can really affect their performance, and that carries over into walking as well. So for vestibular testing, we're looking at the vestibular ocular motor screen, the VOMS we call it. That was developed in 2014 by Muka et al. And what that's doing is we're really looking at their baseline symptoms, and the patient is going to report symptom provocation with the different tests. So they're going to report dizziness, headache, nausea, and mental fogginess on a 0 to 10 scale for each of those items on the VOMS, and we'll talk specifically about what we look at in that test. The positional testing, so for BPPV, benign paroxysmal positional vertigo, that can happen with kind of any type of concussion where they tend to have these vertigo symptoms. The key with that is it is positional dependent. And then the motion sensitivity quotient. So we're looking at what items are triggering motion sickness and motion sensitivity. The cervical assessment, so we want to look at their range of motion, their pain levels with those range of motions, and the stability of the cervical spine. So the postural testing, so the one on the left of the screen, that is our best test. So they're doing eyes closed for all of these, feet together, the Rongberg position, single leg stance, and then tandem stance, 1 foot in front of the other. And what we want to do is look at their non-dominant leg. So if they're right-handed, we want them to be standing on their left leg for the single leg stance and the left foot behind for the tandem stance. And then we assess those same positions on a compliant foam surface. And what we're looking at is error. So do the hands come off the iliac crest? Do they get more than 30 degrees of abduction of the hips or swaying? Is the heel of the foot or the forefoot coming off of the floor or the foam? Do they open their eyes? Or do they fall out of the testing position and have to recover? And then we total up those errors to get our result. And then the one on the right, doing kind of the same, that is the CAT-SIB. We tend to perform what's called the modified CAT-SIB, where we're really just doing conditions without the 3rd and the 6th conditions. You put like kind of a visually disorienting hood or some type of something over their head to kind of disorient them visually, but we tend to just do feet together, eyes open, feet together, eyes closed on a firm surface, and then feet together, eyes open, feet together, eyes closed on the foam surface. So the cobalt was one we talked about in the balance test. And that's one that they're still kind of doing a little bit more research on, but it's very similar to the modified CAT-SIB, where, you know, we're doing eyes open firm, eyes closed firm. But this one also includes eyes closed on a firm surface with head shake and the VOR cancellation, which is kind of a motion sensitivity. And then it does those two things also on a compliant surface. And similar to the best test, we're counting the number of errors or loss of balance in 20-second trials of each. So the VOM, so the vestibular oculomotor screen, and you know, that's exactly what it is. It's a screening mechanism to see where they're getting symptoms, what's provoking their symptoms. So they're going to rate each of those dizziness, headache, nausea, and mental fogginess symptoms, 0 to 10 for each of these items. So smooth pursuits, that's their ability to maintain their gaze on a moving target while the head is fixed. We're going to go 30 degrees in each direction, 20 to 40 degrees per second. So we want to hold a target about 3 feet away from the patient and go in a 1.5 foot movement in each direction. And we're looking for what are called saccadic intrusions, so a non-smooth movement of the eye. There's saccades, so rapid eye movement to bring a peripheral visual object to the fovea as quickly as possible. And we're looking for if they're undershooting, if they're taking increased time. The vestibular ocular reflex. So when we make a head movement, our eye muscles are triggered instantly to create an equal and opposite movement to that of our head. So that's our ability to readjust the visual world, which in turn stabilizes the retinal image, keeping the eye in place and focused on the object despite the head moving. We put that at a 180 beats per minute metronome timer, which is actually really fast. Comparatively, you would not think that your eyes would be able to hold that, but just to kind of give an example, this is 180 beats, and each beat would be a head turn. So it's actually a pretty quick pace. We would wait 10 seconds after they perform that and then record their symptoms, just because it is actually normal to have slight disorientation immediately after that. We would go 20 degrees of motion in each direction for that assessment. The visual motion sensitivity, so that goes at 50 beats per minute. That one's a little bit slower, but they are rotating their head, body, and eyes all as one. And they're going to go 80 degrees of motion in each direction for that one. And then the near point of convergence. So we have them hold, you know, an X, bring it in towards their nose, and we're asking them for when they see double. We're going to take 3 trials of that, and we're going to average the 3 to get our near point of convergence. Our normal measure for, you know, anybody would be 5 centimeters, so that's usually the goal. So this just is kind of a visual of the vestibular oculomotor screen. So the smooth pursuits, moving up and down, left and right, looking for smooth movements and tracking of the eyes, the horizontal saccades and the vertical saccades. So the ability to quickly jump between targets. The convergence, so bringing a letter in towards the nose and measuring that distance from the tip of the nose to the letter and averaging the 3 trials. The horizontal VOR and the vertical VOR, so turning their head right and left at that 180 beats per minute. And what we're looking for is a corrective saccade. So the eyes lose the target and have to make a corrective movement to get back to it. And the visual motion sensitivity, so moving the head, eyes, and arm, trying to keep their eyes focused on a letter. They're going to rotate 80 degrees in each direction, and we're going to record symptoms with all of those. So this kind of gives you just a nice visual of the chart. We're assessing those symptoms with each one of those testings. So some additional oculomotor testing. There's a lot that can happen with the eyes. So we're looking at the optokinetic reflex, ocular alignment, so cover, uncover test. We're going to cover one eye and then remove it and kind of look at ocular alignment. Visual field, so any visual field loss, ocular range of motion, are they able to move their eyes in each of the quadrants? Nystagmus, so direction changing nystagmus, direction fixed nystagmus, and downbeating nystagmus. Nystagmus is just a rapid eye movement. It has a slow and a fast phase. Pupillary light reflex, accommodation. So that's the ability of your eyes to focus on something versus the convergence where we're looking at once something goes double. And the VOR testing, some additional VOR testing would be the head thrust test and the dynamic visual acuity test. So we can have malalignments of the eyes post-concussion. And this just is kind of a picture of some different ocular alignments that we would be looking at as abnormal. So BPPV, that's one. A lot of times, you know, you hear people complain of vertigo, the room spinning, when I roll over in bed, when I lay down. So we want to make sure that if they're complaining of any of those type of symptoms, that we assess the BPPV. So there's two positions based off of, you've got 3 semicircular canals in the ears that are fluid filled and can end up having crystals kind of loose in there, and which will alter the sensitivity. So the Dix-Hallpike's position, usually you want to test the side that you kind of infer will be negative first, and then test the side that you think will be positive, because then you can go right into the treatment. So patient starts in a long sitting position. They're going to turn their head 45 degrees, and they actually have now what they call the loaded Dix-Hallpike, where they would actually flex the neck. So I always tell them nose to armpit, and then they're going to go back into supine with the head extended 30 degrees, but maintaining that 45 degrees of rotation. Prior, they used to instruct this to have the patient hang their head over the edge of the bed, but just to preserve the cervical spine, they've actually found that you can just increase the elevation of the shoulders, and that allows you to get that same cervical angle. And then the roll test for the horizontal canal. With this canal, people tend to complain more of nausea with their motion sensitivity. So you're going to have them go from sitting in long sit to supine with their neck flexed slightly. They're going to look towards their left. You're looking for any type of nystagmus movement, so going towards the ground or away from the ground. Back to center, and then back to the other side. Same thing, you're looking for nystagmus going towards the ground or away from the ground. And that's going to kind of tell us which ear is affected, and we'll be able to treat it from there. So our vestibular interventions, habituation, so repeated exposure to a triggering stimulus to decrease sensitivity to that stimulus. VOR progression, so if the VOR is impaired, we want to work on those. You've got your VOR ×1, where just the head's moving, and the VOR ×2, where the head moves opposite to a target. The visual motion sensitivity training, so you can use virtual reality. Oftentimes, you know, we can get that same response even with having the patient watch a video of walking through a grocery store. Ocular motor training, so their saccadic eye movements with reading, their smooth pursuits. Balance and postural training, so getting them into different foot positions and narrow base of support, eyes open, eyes closed, various surfaces. Their cannula repositioning, so if indicative positive BPPV test, we would look at fixing that primarily in order for them to be able to then go on to other vestibular rehab. So just some examples of some things that we might work on, improving their near point of convergence, so to improve functional tasks. reading textbooks, computers, the horizontal and vertical saccades so that they're able to scan their environment, perform work, drive. Let's see, the dynamic visual acuity test. So that's an eye test with rapid head movements. And what we're looking for is to have less than a 3-line loss. So we do the test with them just sitting, and then we would redo that test with rapid head movements. And we're looking for less than 3 lines loss. Tandem steps, so heel to toe walking, if they're able to take those to get through narrow places in the house.
Okay, and so now we're going to go over a case study. This is a patient that was 29 years old. He was status post motor vehicle accident approximately 4 months prior to seeing us, with a brain injury without a loss of consciousness, resulting in a seizure, speech impairments, mild cognitive deficits, chronic headaches, paresthesia of the extremities, and sensitivity to light and noise. Per the neurology report, patient has associated mood swings, changes in irritability since the accident, and then spinal imaging was done with bulging discs at C4, 5, C5 and 6, L3 and L4, and L4 and L5, and then he had herniated discs at C6, 7, and L5 and S1. The patient also recorded numbness in his left lower extremity and imbalance during functional tasks. Now, this patient was actually, I think the car ran a red light and he was basically T-boned. His car ended up being totaled, but he had basically family issues that he had to resolve, so he did not go to the emergency room right away, and then he saw us about 4 months later. When speech therapy saw him, we did a BADS assessment. In the BADS assessment, they have a couple different tasks. So the rule shift cards is basically a deck of cards, and it gives you a rule. Is this the same color as the previous one? And you just say yes or no. Is it the same color as the 1 2 times before? Yes or no. And he did pretty good. So it's a score of 4 total. 4 would be a perfect score, and he did 3. So he probably missed like 2 or 3 on those. Action plan, that's just basically coming up with an action plan for, we give them basically like a beaker of water and a cork, and we give them all these rules that they cannot do, and then they have to be able to get the cork out of the water. A key search, that's the one that he scored the worst on. So in that, it's an example is you're in a field and you lost your keys. And we tell them, show me the path that you would take to find your keys. And he was unable to configure a path that he would take to find his keys at all. Temporal judgment, it's similar to how long would it take you to wash your windows? How long does it take to blow up a balloon? And he did not do well on those either. Same with the zoo map, it gives you basically 10 areas that you have to visit in the zoo, but then there's rules involved. So you can't go to the same place twice. You can't go down the same pathway more than once. And so that's your executive functioning skills. He showed deficits in executive functioning, attention, planning, and memory recall, and then naming. So our summary was that he presented with a moderate cognitive communication impairment characterized by decreased memory abilities, reduced complex attention skills, decreased problem-solving skills, presented with word-finding deficits, and frequently losing his train of thought. He also demonstrated during the evaluation that he was unable to maintain conversations during that case history. So for our goals, this is just 2 of the probably 5 goals that we had, but they're basically doing complex tasks, but doing an executive functioning task in a 4-second window, completing attention tasks with 100% accuracy. And these are all basically to return him back to his work.
So on the PT assessment, we completed the Dizziness Handicap Index, the Rivermead Post-Concussion Questionnaire, and the BEST test. So you can see the result of those for the patient. We also did the modified CAT SIB. So you can see the 4 eyes open, eyes closed. His balance was pretty good, so we did not vote to adjust the balance portion. We did have orthopedic therapy follow him first to address the orthopedic issues prior to seeing him for the vestibular and balance or lack thereof balance issues. His ocular motor exam showed impaired smooth pursuits. You can see that we assess symptoms at baseline and then with each of the provoking movements of the eyes. And then PT and speech treatment.
So for our speech treatment, we focus a lot on symptom management and identifying the triggers and the management of his symptoms. When we first started treating him, I think I did my whole assessment with the lights off and his sunglasses on. And eventually we tapered that down. We, kind of figured out what was causing him to have these extreme headaches. And it seemed more vestibular at that time. If he had seen vestibular before he saw speech, basically speech was a wash because he was so nauseous the entire time. We did a lot of dual tasking, processing speed, and executive functioning tests.
So for physical therapy, we did a lot of patient education on symptom management, home exercise program development. We usually, day 1 after evaluation, develop a home exercise program so that they are working on things outside of their 2 to 3 hours of therapy per week. VOR cancellation training due to the motion sensitivity, smooth pursuit training, and then addressing any of the issues he had with the BEST test, which is a pretty hard test. So he was pretty high level as far as the balance went.
And here's our outcomes.
So with physical therapy intervention, he was able to demonstrate improved smooth pursuits, decreased motion sensitivity, and was able to begin exertion training in order to return to leisure sport.
Therapy, it was about 12 to 16 weeks, but we were able to identify his triggers to avoid his headaches. We did a lot of blue light filters, earplugs, 15-minute breaks. We increased his processing speed and decreased his mental fog, and we were able to decrease his anomic episodes, so losing his words in conversations. His standardized scores were basically in normal limits, but he still continues to feel like he's not back to normal. So we continue to see him basically to transition him to a home exercise program. All right, and so this is just a slide on basically what our concussion team does and the patient pathways for our concussion team. So they have the injury, they get a comprehensive evaluation at our concussion clinic, which is usually a doctor, an athletic trainer, and they usually do like impact testing. And then they refer them to speech therapy and physical therapy, and then they follow them the whole time until they're back to how they were before. So there's some information if you want to schedule or if you know of anyone that needs it. And then here's a slide about our outpatient rehab services and how to schedule with sports medicine for our neuro team. Here is our references, and we'll just open it up to questions. I'll turn on the video.
Thank you so much, Lauren and Anita, for your wonderful lecture. We do have questions coming in. One of the first questions we have, thank you for your great presentation. I am wondering if you could share how are patients referred to your physical therapy and speech therapy clinic? Do you have any challenges with referrals from the physicians? Some, Anita and I think we're having a little bit of technical difficulty. Okay,
I'm not sure what happened there. Sorry,
yes.
Rick, I might have lost their video and their connection. They're not coming through anymore.
Okay.
So let's go ahead and see if there's any questions from the clinical side that maybe Rick might be able to facilitate answers with from audience members.
Yes, actually, we do have some of the questions. One of the questions is like, what is the difference between the roles of the physical therapist and the physical therapy assistant? So one of the, in physical therapy, we do have physical therapists, physical therapy assistants, and physical therapy aides and techs. So initially, when a patient comes in, especially for a concussion evaluation, the physical therapist basically is the main person who will assess and evaluate the patient. And then we design the plan of treatment. What should we do with the concussion patients, and when do we refer to speech language pathology or neuropsychology, or we refer back to the physician if it's not within our scope of practice, like giving medications if that's what the patient needs. And then as soon as the physical therapist created a plan of treatment, that's when we can do the treatment ourselves, or we can delegate it to the physical therapy assistant, who basically does the same intervention as a physical therapist has, that the physical therapist can do, other than manipulation of the cervical spine. But everything else, the physical therapy assistant has been educated and is equipped to perform those techniques. And so the treatment interventions, the physical therapy assistant can do that, and can do administer some of the outcome measures that has been validated for those concussion patients. So I think Anita and Lauren are back. Just making sure.
Yes,
Yeah.
our computer decided to restart. So we don't have video, but I'm on my phone. So
Yes.
sorry about that.
That's okay.
Okay. So the question was how to refer
Yes.
to our clinic. And basically we have a ED pathway with AdventHealth. So as soon as a patient comes in for a concussion, they usually try to get them referred to our concussion program immediately. And then they can get with our team.
Okay, thank you. We do have another question. It says,
Sure.
do you do all the evaluations in just one session with all with all those tests that speech language pathologists and physical therapy does? So can you perform all these evaluations in just one session? So
We try to do as much as we possibly can within 1 hour. Sometimes we defer to the next session, but we try to get the grasp of basically what we see and kind of go from there to kind of make our recommendations. And then on treatment, we can kind of hone in on the exact thing that we need to get done. Do you have any, Lauren?
Oftentimes we are unable to finish everything in just an hour evaluation. And you have to remember, a lot of these patients are coming in pretty highly symptomatic, and some of these things, or a lot of these things, are very triggering for their symptoms. So oftentimes things have to be postponed just due to patient symptoms.
that is exactly true for us as well, as we do it in our neuro residency program. Sometimes the concussion treatment with all, administering all the sets of tests and measures and referrals, I'm glad that you guys emphasize that concussion rehabilitation is a team effort. It's not a single person. It takes a village, just like any neurological condition. And so we do run a lot of batteries of tests, and when we can't finish it, we do just have to follow up in this next session to perform some of those evaluations. So we do have another question. Do you see inpatients as well as outpatients in AdventHealth for concussions and mild brain injury?
Do we see, sorry, what?
Inpatients and outpatients.
Oh, so
we
inpatient.
actually only work in the outpatient
Yeah.
setting. Oftentimes, just for concussion, those patients are not getting admitted to the hospital. They may present to the ED, but if it's just concussion, they are being sent home.
Yeah, and a lot
and
of
follow up with the physician.
And what we find a lot of the times is if it's not a sports related injury, say they fell when they walked their dog, they might not go to their primary care until 3 weeks later. And they say, hey, I still have a headache since I fell 3 weeks ago. Or, I still keep on forgetting my keys every single time. And this never happened before, but I did fall 2 weeks ago. So a lot of times we get referrals from the primary cares.
So, and I'm glad Anita and Lauren emphasized that concussion is not just athletes. While it is common in athletes when we're in the field and treating them for referrals from the sports physicians, we also have to remember that, in our doctor of physical therapy program, in our neuro residency programs, we see a lot of concussions from older adults and statistics, and even children. And we have to remember that statistics back up that the most mild brain injury incidents are from the older adults as well as younger children. And so we need to be able to screen and assess this age group as well, and not just think of concussion as individuals that are in sports. So thank you for clarifying that. So I do have another question. What deficits do you find hardest to treat in concussion patients, both for speech and physical therapy?
Well, I would say they're basically the same for speech and for physical therapy. One of the biggest or the hardest things to treat is all their associated psychological components. While we don't treat those directly, they have a huge impact on our treatment session. And so it's difficult to treat dizziness, headaches, and mental fog, as they are often present during an anxious state also. So we find that people that have a history of psychological conditions, either anxiety or depression, tend to almost fixate on those post-concussion symptoms. And so ultimately they're their own barrier. Our current MD in our concussion team has started prescribing like low dose SSRIs and has found really good success with that management of that post-concussion.
Yeah, and I would definitely agree. The associated psychological components that go with that. You know, if you think about being dizzy, you know, and this might cause my dizziness, there is a lot of anxiety that does come with that.
Yeah,
and fear of exacerbation of symptoms.
Yeah, and unfortunately, you know, because there's no imaging that can directly relate a concussion and diagnose it, we are prone to ask them, okay, how do you feel? And if we keep on fixating it on them, then they fix on it. And if they're anxious, it spirals out of control.
Yes, that is true. I think it's important for our audience to remember that there are post-concussive syndromes that sometimes do not resolve, and they do last. They tend to last a long time, or sometimes they do not resolve. That's rare, but I think it's wonderful that Anita and Lauren has emphasized the not acuity or even the chronicity of the concussion. And sometimes we get these referrals not immediately after they hit their head, but sometimes we do get them months, weeks, or months after the concussion. And at that point, sometimes it is a post-concussive syndrome. Another question that we have is, what kind of treatment do you find to be most successful? PT and speech. Anita and Lauren, just making sure their computer did not.
Yes.
There we go.
So, could you repeat the question for us? I'm sorry.
Our phone
Yes.
cut out.
Yes. What kind of treatment intervention do you find most successful with concussion patients?
Well, just due to the heterogeneity of post-concussion, the treatments are very highly specific to each patient, but the interdisciplinary approach of physical therapy addressing vestibular, ocular, physical barriers, and the speech therapist addressing the cognitive barriers, as well as the physician managing them medically. The interdisciplinary approach is really the gold standard.
Yeah,
Yes,
I feel like because we have the interdisciplinary approach, we have constant neuro roundings once a week. We meet with our concussion doctors monthly. So we always have that open communication with them. And I think that's the best way to treat them.
Yeah, so one of the questions, we have time for one more question. How unique is the blend of professionals in the treatment of concussion? Basically, the interprofessional care. You know, speaking from the other settings at UCF and in our neuro residency programs, we do treat this. This is the gold standard, like AdventHealth, Anita and Lauren are saying that this is the gold standard in concussion care and even in mild brain injury, as well as moderate brain injury care in inpatient rehab, as well as in acute care, that this seems to be very common nowadays. Do you have any input, Anita and Lauren, on interprofessional, how common this is?
I think it's pretty common. I mean, I think we work a lot with the neuropsychologists, the neuro-ophthalmologists, and then our audiologists in general. But I do think that is the best practice for sure.
Yeah.
Okay, I guess we have one more question. How do you tease out the cognitive deficits of a traumatic brain injury when the patient has a pre-existing Alzheimer's disease or a mild cognitive impairment? Question for the speech therapist.
Well, hopefully, if they have a cognitive impairment previously, we do it a lot based off of caregiver interview. So I talk with the family. Okay, were they able to do that before? And then I kind of, honestly, it's a guessing game. You're seeing what their deficits are now, and then you're taking, okay, what were they able to do before? We have to rely on solely either family interactions and family interviews, or if they've ever been to our services before, to see what their prior scores were and see how off it is.
Okay, I think there's one more. How are processing speed and mental fog outcomes are measured, and are these measures objectively or subjectively? So mental fog and processing speed.
So we do a lot of, for processing speed, we usually do a timed test where we give them like a Strupa test, or we give them a naming task, and we kind of see, are those within normal limits? And mental fog, it's a lot of, we do all these tasks and then we do it subjectively based off the patient's reports.
And we also test this through via VOMS. So VOMS is a very common assessment for younger concussion patients as well as older concussion patients. I think we are about to wrap up. We would like to thank Anita and Lauren for sharing their expertise with us during our clinical case series. So we thank you so much for your time.
Thank you so much for having us.
Sorry about our technical difficulties.
Yes, it happens sometimes. So
Yeah.
with Zoom. So thank you so much, and everyone, thank you for joining us today. And we'll see you next week for the next clinical case series. Thanks, everyone.
Thank you guys for having us.
Thank you.
Bye-bye.